So it's a great pleasure to be here and see so many familiar faces and some new ones too. We had actually hoped that we could have this at Dell Med School today, but the numbers got too big. We couldn't we couldn't house this number of people, which is a wonderful thing. I want to just recognize Daniel and all the work that he put into organizing this. He obviously didn't do it alone, but we wouldn't all be here if he hadn't pushed this forward. So, I think that's wonderful leadership, the kind of leadership that we absolutely need in issues as important as this one. In some ways, I'm speaking to the choir. You all are going to know a lot of the things I'm talking about, but I still think it's useful to talk about where we are. I'm really focusing on the current paradigm and how we could think about moving forward broadly around the current healthcare system, not specifically around pain and a substance use disorder. This is hard to read, but I recommend that you pull this up because I just find this chart really fascinating. And it's easy to find, and I can share with you the my slides so that you can look at it, and I've put it up on Twitter as well. I'll do that after today. But this shows by country over time cost, and cost is on the x-axis, and life expectancy. Cost per person for healthcare. And it starts back in 1970 and goes to a couple of years ago. And you can see all the countries are going up nicely in terms of life expectancy, also in terms of healthcare expenditures. I think you can see Switzerland's up there, kind of at the top right. Chile, you can see, has a life expectancy of 81 and a half years. Let's see if I can get this to work. 81 and a half years, and spends about $1,500 per person per year for that life expectancy. Obviously, there are other investments that are made, but healthcare is a big expenditure also in Cuba. But compare that to the U.S. So in the U.S., we were about like all these other countries, both in terms of life expectancy and expenditures. That's back in 1970. But as you can see, we've fallen off that curve, and our expenditures have increased dramatically. This is the last point that they've shown on that they showed initially in this data, so that by 2014 we were spending just under $9,000 per person, and our life expectancy had actually drifted well below all these developed countries, well below Chile, and in fact even below Cuba, which isn't on this chart, but spends even less than anyone else on this chart. So major increases in expenditures, no benefit in life expectancy. It's not unique to life expectancy. In fact, if one looks at global markers of health, we are well below any other developed country. And when one considers how much more we spend than any other country, it's a horrible disconnect. Even worse, and this should have been animated, but it's not, if you actually plot out what's happened in the last 2 years, we're pretty much the only country that's seen a decline in life expectancy, and in spite of a major increase in the last 2 years in expenditures for healthcare. So we're $10,800 per person for healthcare expenditures, and now are drifting down, not up. And of course, we know major contributions to that, one of them being the topic of today and tomorrow's discussions. So, this is terrible. We should absolutely have the best health and health outcomes in the world, given what we spend, and yet Cuba, Chile do much better than us. So there are a lot of issues with our healthcare system. I'm gonna sort of bring it down to a small number, just to get us thinking about it. Healthcare is not the automobile industry and the way we think about how we purchase automobiles. So we're in a kind of semi-capitalist system with healthcare, right? So there is some purchasing of healthcare, but not necessarily by individuals. So when you go to buy a car, you look at the price, and you know the price, and you look at the features. And some of those features you can just see. You know, there's styling, and there's you could drive it and feel how fast it goes and how excited it gets you, and marketing helps you to think about that. Some you can't see and require further measurement over time, like reliability. So think about how impactful Consumer Reports has been in telling us about what are good and bad cars, and how that shifted things. And that reliability requires somebody to do measurement and continuous measurement and feed that back and feed it to us, the consumer, so we can make a good decision about cars. Now, price then becomes one key factor when we make a decision about a car. Are we willing to pay more for this or that feature that we as individuals value? That's the reason capitalism works for this. It's in the control of the individual. The individual has all the evidence that they need to make an informed decision. Those informed decisions then drive the producers of automobiles to produce the kind of cars that we're willing to buy at prices that we're willing to pay for them, right? Okay, so now let's convert this. Well, it ends up that the range of cost for joint replacement, for knee replacement surgery, is about the same as the range of prices in these two automobiles. So from about $17,000 to $61,000. Obviously, there are outliers on the upside, no real outliers on the downside of that. $17,000 to $61,000 for a joint replacement surgery. All right, so then how do any of us make a decision about price and who we go to, which of these joint replacement options we have in front of us and how we choose? Well, the reality is we can't see the quality in those two choices, right? So for one thing, bedside manner. Maybe bedside manner is the sort of look and feel of the automobile. It may matter more in an automobile than it actually does for the outcomes of surgery, right? But that may be all we have to go on. And in fact, that does appear to be the major predictor of how patients get referred to certain physicians, much more about their bedside manner than their outcomes. We don't actually know the surgeon's outcomes very well. We don't track them. Even if we think we know them, we're often wrong. When we do track them, we discover that their true outcomes have nothing to do with their reputation in the medical community, that's often unknown and unknowable because, again, we're not tracking, we're not keeping any knowledge. We don't have that knowledge of the data and the outcomes. On costs are unknowable, right? When you go to a surgeon to get multiple opinions about whether that's a surgeon for you, they are not going to quote you a price. You can't know what that price is. And also, you're not sensitive as an individual necessarily to that price. More and more, we're becoming sensitive to it as more and more of the costs get borne by the individual patient. Also, the system itself isn't then motivated to improve the quality, to improve the outcomes, because someone's tracking it and someone's going to a practitioner that has better outcomes. And in fact, the healthcare system resists assessment of outcomes. And then without that feedback, we're not creating the constant improvement that we've seen in cars and in all other industries. Think of cell phones and laptops and all of that. We're not seeing those improvements that we absolutely need because no one's tracking it and valuing it. The volumes aren't directed to it. So no surprise, of course. I mean, these are things that are obvious to us, but they're not obvious to us, right? We've lived in this system for so long, we forget just how dysfunctional it is. So fee-for-service is a major issue here, and the intermediaries in the system make it even more difficult for fee-for-service even to work. If it was fee-for-service for haircuts, you're willing to pay more for a good haircut, right? And you can see that haircut. The price of the haircut, you can see the impact of the haircut. We don't have that in healthcare. We can't tell you whether it's a high-quality haircut, and you don't know the price. Okay, this is another sort of emblematic picture of our healthcare system. So why? So the hospital gown has been in healthcare for over 100 years, pretty much unchanged. the little patterns and things might change a little, but this basic design goes back to the late 1800s. And it ends up, it's a horribly dehumanizing thing, right? I mean, anybody in the audience enjoy putting on a hospital gown? And just the notion that one would be comfortable having their rear end exposed, I don't know how that was ever conceived that would make sense. One, in the healthcare system, you think if you're outside the healthcare system, there's somebody who has a need for this, right? Maybe the nurses need it, quick access to the back or something. The reality is nurses spend a whole lot more time covering people up than wanting immediate access to the back, right? I mean, that just doesn't happen. And for docs, no, that's not what docs want. When you approach a patient, you're happy to lift up a shirt and put the stethoscope there and in the back. This is not functional. So since the 1800s, we've had these hospitals, not thinking at all about how they make us feel as patients, and no one's changed it. I mean, think about a system that allows that much disconnect from treating our patients as people and never innovates a very simple thing. T-shirt in boxer shorts would be more comfortable and a better solution. Hardly a new design, doesn't require much, can be very cheap, and yet we don't allow for that in our systems. So I think to me, this one's it just kind of encapsulates, wow, not only we've set up this system that doesn't make any sense and doesn't auto-regulate, we actually don't even innovate really, really obvious things. This one, I mean, we're not the only, somebody pointed out that it took us, hundreds of years to figure out to put wheels on luggage, right? So it's not that this is the only area in which it takes us a long time to innovate. But this one's silly, and it just shows a real disregard for how people feel in our system. So when I have more time, I go through all the other sort of things that should be obvious to us about how the healthcare system's broken, and I'm not going to do that today, but it is broken. We all know that, and we all see that, and that's partly why we're here, is to try to come together and think about how to fix it in this important series of conditions. We're highly invested in the status quo. And doing more rather than doing better. Our system really encourages that. Fee-for-service encourages that. We get a lot more money for treating the sickest than promoting health. Our current system doesn't even pay for a lot of things that we could do within the community to promote health, but it pays a whole lot for an ICU stay or a major surgery. And so we tend to focus all our energy in the healthcare system on doing more and more of that stuff. We end up being resistant to technologies, not that we can get a lot of payment for in the sickest patients, but and other approaches that might improve efficiency because the fee-for-service doesn't value those. So email is a perfect example, right? I mean, hardly a technology, but it doesn't really work in healthcare. We push it aside. It should work in healthcare, and the people blame the regulations for that, but in fact, it is a very workable system to be able to email with your doc, and how valuable would that be. But your doc doesn't get paid for an email. In the current healthcare system, that's largely uncompensated, and that's the real reason it's resisted, which is ridiculous, right? So much could happen very efficiently and more effectively through that kind of communication. It's not just that the healthcare system, the traditional healthcare system in clinics and hospitals is broken, but the way we think about our community health system is also broken. So the vast majority of attention is on docs and their tools, so pharmaceuticals and devices, and then now some on care settings, and you all talk some more about that, what's happening, how groups of folks come together to care for patients. But if we really want to have impact on outcomes, it's really getting out into the community where we're going to make a difference. Interfacing that community with what happens in the clinic, taking responsibility for people wherever they are, that's the kind of place that we're going to have the greatest impact. Well, why? Well, healthcare maybe contributes 20% to health. 80% is really determined by things that happen outside the healthcare system. So unless we get out there, we're not going to be able to have any kind of impact. And exacerbating that is a lack of knowledge on what's going on in the healthcare in our communities. And the next one shows you a picture of a city, and it's just to show, the IBM had that sort of smart city thing, track all this info on your city. So, but when they were talking about that, they were talking about, police and fire and traffic and electricity and all that stuff, and not about health. And really, we can get this data on health. I mean, we're currently not, but think about the folks that you all are going to be talking about over the next couple of days. We should know what's going on with them, not just by neighborhood, but how they're moving through our systems. We should be tracking that data. We should be using that data, learning from it in order to improve the outcomes for those folks. The way in which we learn in our system is far from ideal. So we rely on research to move things forward. And we put this wall between what we call research and care. So if it's research, then we think, okay, you need a grant for that, philanthropy or NIH dollars. That takes years and years to cycle through in innovations, right? Just to get grants is extremely difficult, and then to execute on them and all of that. Then you rely on publications to change practice, and we all have seen how impactful. I mean, we know there are a whole bunch of models that work. Why aren't they being used all over the US? And so those papers by themselves don't have the impact. And then we have care on this other side, and we don't really study things in care the way we should to learn from it as we go from every patient that we treat and feed that back into our systems very quickly to make those course corrections. So if we have a picture of if I think about what our healthcare system looks like today, our whole health system, it looked like that. Okay, now it's going to catch up, so it's going to go while I talk. So in that rock, we cannot allow our system to exist this way any longer. I mean, it's been so hard to make these changes. They're changes that are really obvious. Just take a little step back and you see just how dysfunctional the paradigm is currently. And so that was for me the real appeal of coming here. So Austin, great city for doing things differently, having a vote, the community voting to increase their property tax, to have a med school here, fabulous connection to this community through that. But really, too, not having a bunch of people to say, no, you can't do that. No, you can't do it. And the biggest driver to that, even in very creative, innovative institutions, is that they're optimized for the current system. And any new system puts the current system at risk. That's the real barrier to this being done at established academic medical centers or any other established entity. And what do I mean by that? Well, fee-for-service works beautifully to produce margins at academic medical centers all over the country. In fact, they rely on those margins to cross-fund education and research, which are huge money losers. And so if you put that at risk by doing it something a different way that maybe reduces the number of hospital stays required and has beds open and maybe MRI machines not used, you've put that whole model at risk. So starting from scratch, we don't have any revenue from fee-for-service. We can actually approach each problem and ask, how should it be designed? How can we do it better? And that is unbelievably liberating. And again, we're not alone in being able to take that approach. And that's sort of what I'm encouraging, is that you all think about what it would mean to really start from scratch. For us, then, it's about the ecosystem. And it's about how we enhance health innovation. So, our vision is a vital, inclusive health ecosystem. So we're about that and how we support the ecosystem. We're not about a top 10 medical school or worldwide innovation. No, we're about how do we produce that ecosystem that then allows for health innovations to happen. And in one difference, one place to start is with the person that is really the one we serve. We don't serve providers, we don't serve hospitals, we don't serve insurance companies, we serve people. We hope that those people don't become patients, because Very few people want to be patients. So if we care about people, we want to keep them as people and not as patients. And then we want to do whatever we can to empower that person to stay healthy and live a life they want. So what does that mean for that perspective on the person? What does that open up? Well, it opens up being disciplined around doing the right thing, not caring whether you get paid for it or not. And that's a tricky one because ultimately you can't afford to do that forever. But you can afford to do it while you demonstrate that you can produce a better product. A better product being better health at a lower cost. No individual wants their resources wasted. And this gets a little tricky because it's like if it's not their resources, then they don't care as much, right? But the reality is, in aggregate, when I'm treating one patient, it has an implication for the patient who's coming next. And so we do need to think about the resources that we spend on any one patient. And it also reminds us that this is a person, and people are complicated. They're not diseases. And as complicated people, they have an emotional state and a series of other conditions that are impacting their health that may be even more important than the specific health condition that you're treating. And that we have an obligation to, in order to produce the best health outcomes possible, to address the emotional aspects for the patient and all their life chaos issues as they impact their health. So, some of our group, Elizabeth Teisberg and Scott Wallace, talk about capability, comfort, and calm. That those three things then become our obligation because all three of those are critical aspects of producing the best health for people. And if you don't deal with them, they're gonna get you. They're gonna get you because whatever you say, whatever you prescribe, isn't gonna work when the person gets back out of your office. So one of the issues too is we have to promote a much more rapid cycling of innovations. And so we think about this, the lean startup model, by looking at, evaluating things on an ongoing basis for the things that we do and feeding that information back into our system to make course corrections. And doing that in real time. So it's our job actually in the healthcare delivery system to produce the research, what used to be called research, we call it innovation, in order to drive the system forward. We shouldn't wait for the government to fund that stuff. We should build that in actively into the care that we're providing. And then for us too, it means our focus is different. If we focus on Dell Medical School and us being, strong and great and all that, then we're losing track of our obligation to focus on people. And then our success really should be determined by the people in aggregate. And you can draw this circle a lot of different ways, and we do, but simply making Austin a model healthy city. What does that mean? Well, we're not going to do everything, right? We're not going to provide housing for everybody, but we might actually encourage and show why housing is critical for the health of a group of patients, and we might even encourage moving dollars that have been wasted in the healthcare system to housing to produce a net gain in quality of life and in savings. Okay, so I'm going to make it real with one example. I could give you a bunch more, but this is the example that's farthest along. Joint pain. All right, it doesn't sound like it should be a number one priority, but it was an early priority for us for a couple reasons. One, it is now the number one expenditure for Medicare. And a lot of joint replacement surgeries, obesity contributes to it, overtreatment probably contributes to it as well. I'm sure you guys it's probably number one for you or number two, I don't know. But it's number one nationwide. We also, in the county, in our safety net system here at Central Health, the county health district, we had a 14-month waiting list. Over 1,400 people on that wait list to see an orthopedic surgeon. Some of those people couldn't walk, and that's a long time to wait to see a physician. So it became a priority here. So we completely redesigned that care, and we have the team to do that, and I'll tell you a little bit more about some of those folks later, but you bring creative people together from all different disciplines in order to think about how that should be redesigned. Don't just tweak a current model, because that model was developed for other things: provider convenience, provider profit, and you really want to redesign it from the bottom up around the person. And in that is appropriate triage. So this was a big problem before. Who can manage what, and who needs to be seen when? And a lot of that can be done electronically and through phone calls. And then around the care of the patients who are seen, there needs to be counseling. It ends up that the emotional state of a patient is the most important, more important than surgical technique in defining outcomes for surgery for joint pain. And one of the guys who did a lot of that work is on our faculty, a guy named David Ring. And so that needs to be available. Assess the emotional state, see how we can modify it. And then physical therapy, training, dietitian, so weight loss, smoking cessation is important, diabetes control is important. All of these are critical factors in managing joint pain. And then constant measurement and adaptation. So that program, it has been going now for about a month or a year and a quarter. And within 2 months, they had gotten the wait list down to pretty much 0. So they'd gone through all those patients, most of whom they'd seen. And then I'll show you their summary of results. So if you look at the total patients that they were able to see, they could see many more patients in the system. The orthopedic surgeon was in the middle, not at the front end. And so they had all kinds of ways in which to start caring for the patient before the orthopedic surgeon was involved. The need for surgery was reduced by managing the risk factors. So the surgical rate is at least 50% lower than what it was previously, and no one who wanted surgery was denied. So just to be clear, this isn't a rationing approach. It's dealing with the pain and avoiding overuse of surgery, which can produce more pain than is necessary. There was, of those who got surgery, the lengths of stay were dramatically shorter, and they were much less likely to be discharged to a nursing home or a rehab hospital. Most of them went home. So they were prepared for surgery, and the surgeries were done really well. And then some of the surgeries we could even do in an outpatient setting, things that weren't even possible before, which is better for patients, more convenient, and a hell of a lot cheaper than a hospital stay, and a hell of a lot safer than a hospital stay. So all in all, that was a huge success. Now there's 0 wait list. We continue to see patients in that system. It's produced dramatic savings as well to our partner, Central Health. And that shows you what you can do. So you can produce better outcomes at a much lower price. Patient satisfaction is really high with that, and now that is offered to the commercial market as well as to the non-commercial market. So we can create I don't know what it would be. We're not trying to create a Lexus, but we're trying to create something more that moves like as reliable as a Lexus, without luxury items, but that moves fast at the price of the fiat. That's basically what we're trying to achieve. To do this, you need creative partnerships. A lot of this stuff we can't do by ourselves, and working differently with communities and how we bring them in, working differently too with businesses. So it ends up, right now, because people don't pay generally by themselves for those costs, and Central Health is an example of an intermediary. We need to work with these intermediaries too to make it work. So Superior is another example of an intermediary, an entity that's actually taking risk and has the best interests of its covered population in mind, acting on behalf of a group of people, their voice. So the other is self-insured businesses. And also governmental entities that manage multiple people, like Teacher Retirement Service. So we're working closely with them on how we how we help them with their priorities and find better solutions to them. So what we're really trying to do, we don't think this is just our job. If it is, then we will fail, right? It's too big a job. It's too hard to different populations. I mean, the work to just deal with joint pain, which is, you know, important, but it's only one entity, was tremendous. We need to actually think about this as a platform. How do we create a platform where the innovative ideas can move to benefits of patients much more readily? And so whoever's coming forward as an entrepreneur or social entrepreneur with those ideas can get the support to move those innovations forward, because that's really what's going to enable innovation. It can't be in the hands of just a few people. It needs to be open to the people who understand the conditions, understand the populations that need to be served best, playing by a rule book that makes the most sense, that's best aligned with society's interests in health. So how do we think about that? Well, part of that platform has to be measurement of outcomes. We have to know what the outcomes are. If we're going to get paid by them, if we're going to direct people to them, if we're going to encourage people to constantly improve, we need to actually measure outcomes that matter. You know, there's now this pushback on measuring outcomes, and yeah, measuring outcomes that don't matter, I mean, I'm all with you there, but we can measure outcomes that matter, and we can get paid for them, and then they really matter to different entities. So that's the next one, payment for value. So when we produce better outcomes, we should get paid better, right? I mean, that just makes sense, just like the barber shop that we just talked about. So how do we start to produce that? And outcomes does mean not having waste in your system. So that ought to be accommodated as well. And fortunately, now we've got faster movement in creating these value-based payments that we're talking about. That needs to move even faster forward. Design, human-centered design, ends up being a critical element here. We're not, physicians are not necessarily trained to be creative people. And some would say they're just not creative people. But I wouldn't say that. I wouldn't say that. And our healthcare system certainly hasn't drawn the most creative folks into it. We need to invigorate our health systems to being creative. One way to do that is to introduce these human-centered design concepts. And we've done that at Dell Med. We got a whole shop that does that. They're fabulous. And that is really useful as part of this platform. Yes, you do need clinical expertise. The thing, you've got all these entrepreneurs working on these new systems of healthcare, and they're doing some really cool things, but they often really don't know what's going on in the healthcare system. Have you noticed that? You hear about these ideas, and you're just like, yeah, that's a cool technology, but no one, who's going to pay for that thing, So we need that clinical expertise actually built into the platform so that people understand what will and will not work. Teams are really going to be the way of healthcare for the future. Individual management of patients just doesn't make sense. It's not good for physicians. It makes them unhappy. It's inefficient. And it doesn't take advantage of all the expertise that exists out there in these other areas that's absolutely critical for solving these problems. And then technologies are going to be critical for this platform as well. It's kind of ridiculous that technologies have changed every single industry dramatically. And the major change that technology has produced in healthcare has been to make doctors unhappy and patients feel less connected to their doctors, right? Electronic health records. Number one source of dissatisfaction in patients, major draw away from caring for patients. Patients hate seeing the back of their doctor's head. And that's the big advance in broad technology in healthcare. That has to change. The technologies really need to be disciplined around the person and how actually we enable the person to assume more responsibility and care and have a more active role in their health. Okay, so how about I should have said chronic pain and substance use disorder, but what would this look like? So we all have seen different models out there, and there's some fabulous models and models that work. Models need to be adjusted for the populations that we're serving. We need to think about the segmentation that makes sense to appropriately address these groups of needs. But what does a complete redesign of this care look like? The triage could be very different. When I think about some of these folks who who receive Narcan and then immediately leave the emergency room and shoot up again and die. And the number of cases like that, it's tremendous. We're not obviously thinking about triage and really caring for people in and out of the hospital setting. The pharmacy management, risk factor management, counseling that goes with that, constant measurement and adaptation. What's possible if we apply these pieces? We think about that platform, we apply these pieces. Obviously, we need different payment mechanisms as well to reinforce what it is we want to achieve through the system. What could we do? I mean, I think it could be so much better. It's got to be so much better, right? It's horribly dysfunctional. And so I'm excited for the work that you all are going to be doing in the next day and a half, and I hope that spurs on a tremendous additional work in this area because we absolutely need it. Ultimately then, I think I'd have one last slide, and if it doesn't show, I need to be thinking about 30 seconds ahead. Click the button, and then go back. There we go, yeah. So ultimately, the goal should be, how do we liberate entrepreneurs? How do we liberate people, social or traditional entrepreneurs, to come forward with the great ideas that we need? How do we give them a platform, work with them in order to rapidly accelerate the innovations that are required in the health system? Thank you very much. So any questions? Yeah.
What's Dell Medical doing in regards to the gown?
To the gown? So what's Dell Med doing in regards to the gown? That's a great question. And we've had a bunch of discussions about whether we should focus on the gown at this stage. If we did it, it would be just to show that we can do it. And so there's, I would say from the first year we've talked about the gown. We will deal with it. I'm not sure if it'll be this year. Our design institute's actually ready to redesign it, and the school, the textiles group at UT is also really excited to do it. There have been a couple other designs out there, but none of them is actually adequate for what's necessary. Yeah.
Well, I'm a family nurse practitioner, and I've been a nurse for over 30 years. That gown may not be great for providers, physicians, PAs, and nurse practitioners, but as a registered nurse on the floor, that gown is invaluable. When you've got someone who's got to be to the bathroom in like 2 seconds, to get them on a bedpan, to get them do all the things you have to do as a nurse. So that gown is very functional if it depends on what your job is. To have a pair of boxer pants on a patient and trying to get them off and get them on a bedpan is going to make it harder for our people that are there with them.
I think that's part of the, I mean, I don't want to spend a lot of time on the hospital gown. We got bigger problems to solve. But I think your point is interesting. We have to look at the various perspectives, and we have to find a solution that meets all our needs. But I would say from a patient perspective, whether those uses overwhelm your sense of self and decency, and also seeing how RNs have had, I mean, I'm a stroke doctor, so seeing how often the nurses are covering and recovering patients because they're constantly coming uncovered, I wonder about, in the balance, whether it's worth it. But you're right, we need to think about all the different practitioners. Yep. Was this the?
Thank you very much. This was an exciting presentation. For these innovations, and I know it's early, what are your thoughts about scaling them elsewhere, the dissemination
Great question.
of typical models or publication? You're really talking about the dissemination implementation issue.
That's correct. So the question is, what do okay, you're going to do this here in Austin, but how are you going to disseminate this? Typical model would be to publish on the model. We're happy to publish on the model, but I agree with you, that's not going to work. We've seen what publications do. We actually think that we need disruptive entities, nonprofit, for-profit, that move in and spread these ideas and move in and disrupt the marketplaces in other places. Now, we have no interest in moving the Dell Med brand across the country, but we're happy to work with partners to think about how these things get disseminated to other cities. So, could we create that joint pain model in Omaha? Absolutely. We can provide the intellectual input and the sort of the template for it, but we don't want to manage a company that's doing that. But we're happy to work in conjunction with others. So, and we've had discussions with potential partnering companies and also about starting companies. And so that is part of our goal to go forward, is to think about what these new business modes of dissemination might look like.
We're going to have to cut it off
Okay.
at that point, but let's hear it again for Dean Johnston.